My son, please. Yeah. Eh.
So I would like to thank Dr. Kang, Tin, and the team for the invitations to be part of this exciting meeting. So I will present my slide in English. Oh, bahasa Melayu. All right. So basically, this is a very broad topic. All right, the role of cardiac catheterization in the management of PA-VSD, because we know that PA-VSD management is very wide spectrum, starting from the initial palliation, diagnostic, and can be therapeutic for the future intervention in PA-VSD. So basically, the three important aspects of cardiac catheterization in PA-VSD. One is for the diagnostic, because we need to delineate the native pulmonary artery, and also those with major aortopulmonary collaterals has to be delineated before the corrective surgery. And of course, for those who had Rastali surgery, in the future, you may need to do a hemodynamic study, especially in the presence of the conduit stenosis. The second aspect is basically the therapeutic, all right? Those for patients that are suitable for PDA stenting. I think we discussed this in length this morning. As an initial palliation, also rehabilitation. I think once you embark in the PA-VSD program, especially those with unifocalizations, so you have to do a lot of rehabilitation for these pulmonary arteries. And for those who had a blocked surgical shunt, then we may to consider to recanalize some of the surgical shunt. And not to forget the follow-up assessment, especially the functional assessment of the conduit, and also transcatheter pulmonary valve implantation in the future. So this is the spectrum of pulmonary atresia ventricular septal defect. It can be those with simple PDA coming from the base of the subclavian artery, behave like a native BT shunt, and those with tortuous PDA and in the presence of branch PA stenosis, or you call it a pulmonary coarctation, or those with a bilateral PDA. I think this wide spectrum already well delineated by Dr. Hai just now. And also maybe those patients with in the presence of a lot of MAPCAS and collaterals and small native pulmonary artery, or even without a native pulmonary artery. So for our institution, those with pulmonary artery and MAPCAS, we usually do both angiogram and also CT scan. This is complementary each other, especially preparing patient for unifocalization and also either shunt or limiting conduit. Example, this patient is at the neonatal age. We do basic angiogram, especially the aortogram, and also injection, the selective injections to see the presence of native pulmonary artery. And this is always complementary with a CT scan, especially to decide what is the next management for this group of patients. So this is a simple example. This is a 6-month-old patient with PA-VSD MAPCA, and this patient basically was prepared for unifocalization surgery plus minus RVPA conduit surgery. So this is the initial diagnostic catheterization, which showed multiple MAPCAs, and the selective shot showed presence of a native, good-sized native pulmonary artery, and some other selective shot showed probably stenosed takeoff of the MAPCAS. And this is again complementary with CT scan. And we always had our MDT discussion to decide on the further management of this group of patients, as either surgical shunt versus unifocalizations, or limiting RVPA conduit, or total corrective surgery, or maybe if there is no native PA, patient is decided for conservative management. All right, so again, I think we discussed in further detail this morning about the complex PDA anatomy, either suitable or not suitable for PDA stenting. So example, I think CAF is also gold standard to assess a PDA morphology, all right, to assess the origin of the PDA, either underside of the transverse arch, the tortuosity of the PDA, either the PDA is elongated with multiple curve, and this type of PDA is technically challenged, but in the presence of the current technique, example like the rotational angiography, which you can reconstruct the images, behave like a CT scan, and then you can decide what route or the IV access, especially to place the stent. All right, and not to forget, I think that another diagnostic area is basically the follow-up assessment, all right, and planning for the conduit change. For example, this patient, all right, I think this is to highlight to our surgeons, this is what the conduit behave after 15 years of implantations. It's heavily calcified and also stenos most of the time at the incision point in the RV connection, and also the distal point in the pulmonary artery connection. So this patient has a severely calcified conduit. And at the same time, it can also assess the branch pulmonary artery, aortic root, and also coronary artery before you embark on the percutaneous pulmonary valve implantation. All right, so PDA stenting in PA-VSD, I think Tin has, I think, more experience than me in PDA stenting in PA-VSD. And example, this patient that I've presented before, those with rotational angiography. So this patient, we can easily plan for right axillary approach to place the PDA stent. All right, so the stent is placed nicely, and I know there's a presence of branch PA stenosis, especially when you jail the left pulmonary artery. But these patients usually had good growth of the jail pulmonary artery, and still a good anatomy to proceed with the surgical repair a year after the PDA stenting. All right, and as we know, I think PDA stent, as Siva mentioned just now, I think on the our AHA guidelines 2011, and this was revised in 2015, the dark stenting in the presence of pulmonary artery stenosis remains as class 3 indication. However, I think this is based on the very scanty data. I think there's more and more publications on the PDA stenting in the branch PA stenosis, especially, as I mentioned before, in the presence of our capability of our surgical colleague, that they can repair the PA even less than 1 year of age. And also the better technique of PDA stenting, especially in the complex PDA, I think we can stent almost all type of PDA depending on the institutional practice. All right, so with the presence of good images, I think you can plan your PDA stenting procedure, either transvenous approach from the VSD, or right transaxillary approach, or left transaxillary approach. And it can also be a hybrid procedure with your surgical colleague for the karate approach. So example, this patient who had right axillary approach PDA stenting, which most of the time this is our preferred assess for the PDA stenting, where you can see the PDA is approached directly for the right axillary approach, and this stent was basically this coronary guide wire was placed in the distal pulmonary artery. and the stent is further delivered and also inflated and nice flow after the PDA, after the stent implantation. So in another, not uncommon to have a carotid approach. This is usually done in our regular cath lab with our surgical colleague assist us to get the access from the carotid. And this carotid approach, usually we do it as hybrid, where our surgical colleague will open up, cannulate the carotid artery, and pass through the sheath, the 4 French sheath, and this is usually directly enter the PDA, and we can always do good angiogram directly into the PDA and delineate all the pulmonary arteries. And the stent was then delivered. This is a open cell coronary stent, and you can get good result after the carotid approach. And this then followed by a final angiography, which showed good pulmonary artery size and the stent flow. And this carotid cut down is then repaired by our surgical colleague to end the procedure. So another therapeutic role is basically to recanalize the surgical shunt. Example, in this patient who is 1.5 years old with tragedy of phylopulmonary atresia, who had BT shunt in the neonatal age because of the hypoplastic left pulmonary artery, and was discharged home very well and presented again with severe cyanosis, and initially was referred for a single lung repair. And the LPA was not seen on the 2D echocardiogram. So what we did was we did the initial angiogram, which showed a blocked BT shunt. You can see the stump in the subclavian artery, left subclavian artery. And initial attempt was basically via transvenous approach, and coronary guide wire was introduced basically to try to recanalize. And then we use a RF wire again to recanalize this block shunt. This again retried with our CTO wire. Initially was a 9-gram Conquest Pro guide wire, and followed by a 12-gram coronary guide wire. So then I think this guide wire was placed in the distal left pulmonary artery. And followed by stenting, and you see the good flow, the final angiogram, the good flow into the left pulmonary artery. And this patient underwent successful TOF repair with LPA reconstruction. So initially was planned for single lung repair, and this patient ended up with good 2 lungs repair. All right, and not to forget, this is the patient that I presented I think in the previously. This patient had total repair, unifocalization, and RVPA conduit at 6 months of age. And about 2 years of age, we noticed the PA was, the conduit was a bit dilated, the pressure was a bit high. So we proceed with the CT scan. We showed multiple stenosis at the unifocalization area. So this is the initial angiogram. You can see here, I think the upper lobe stenosis, multiple branch stenosis. So if you embark on the unifocalization program, I think you need to be prepared that this kind of a pulmonary artery has to be rehabilitated, and multiple intervention are required. So this is a balloon angioplasty of the right upper lobe branch. This is angioplasty of the left lower lobe branch. So yes, we get good result after the balloon angioplasty. But again, I think this demands commitment from everybody, the imaging cardiologist, congenital cardiothoracic surgeon, and also interventionalists. All right, so not to forget, another therapeutic role is basically the transcatheter pulmonary valve implantations, maybe years after the Rastali procedure. Example, in this patient who is 23 years old, who had Rastali surgery 15 years ago with using a pulmonary homograph, and when presented to us 15 years later with a RE pressure of 2/3 systemic and heavily calcified conduit. So this patient has had coronary assessment, balloon dilatations of the conduit, and also placement of a covered stent because of the heavily calcified conduit. So this covered stent is the size of about 20 to 48 millimeter. And this was then followed by melody valve delivery. And this melody valve was then inflated, followed by bigger balloon inflation. This is 22 size Atlas balloon. And the final angiogram showed good valve position with no pulmonary regurgitation. So in conclusion, catheter procedure play a very important role, especially in the management of pulmonary atresia ventricular septal defect. So we can use a cath procedure as a diagnostic tool and also interventional procedure. And PDA stenting, I think, in comparison, provide good alternative to the surgical shunt with less morbidity and mortality. However, in terms of longevity, it's probably less, but I think it's good enough in the setup of early cardiac surgery. And catheter study and CT angiogram always complementary each other in the management of PA-VSD, especially in the presence of MAPCAS. And re-intervention procedure like ductal stenting, restenting, recanalization of block shunt are good options basically to optimize the anatomy before the corrective surgery. And most important, the collaboration in between interventionalists, imaging specialists, and congenital cardiothoracic surgeon is the key point here. And surgeon can always stand by for the complication of cath procedure and also planning in the future corrective surgery for patient with PA-VSD. So with that, I thank you for your attention.